Welcome to the Animal Heartbeat. This is the world's greatest and only podcast dedicated to veterinary cardiology. I am Kieran Borgeat.
And I'm Novo Matos. So welcome everyone to the Animal Heartbeat, your veterinary cardiology podcast. Today with us, we have a special guest, Dr. Ryan Fries. Ryan is a board-certified veterinary cardiologist by the ACVIM and is an associate professor of cardiology at the University of Illinois. Ryan's research and clinical focus has been mainly on advanced cardiac imaging and biomarkers and interventional cardiology. We're very happy to have Ryan with us today, and we'll be talking about advanced imaging in hypertrophic cardiomyopathy. Ryan, it's great to have you with us. Welcome.
Well, thank you for having me. I really appreciate it.
It's great to have you join us. I think whenever I think about feline HCM and the potential for advanced imaging, I'm thinking about assessing diastolic function, assessing early systolic dysfunction, assessing fibrosis, and hopefully these are all things that we can think about covering today. Can we start with tissue Doppler? This is something most of our listeners will be familiar with the concept of, maybe use it themselves on a regular basis. Where does tissue Doppler sit in our toolkit as cardiologists for assessing feline heart disease?
You know, to me, it's a fundamental aspect of assessing cardiac disease in our feline population. As you stated, right, this is a diastolic disease. We know that is going to be an early marker potentially. I guess the biggest caveat to tissue Doppler itself is that we know that there's a spectrum of diastolic changes that occur in our normal cat population as they age. And as a result, I think we can often find ourselves maybe overreaching when using tissue Doppler specifically for assessing, slight alterations or early alterations in sort of diastolic function. And so, we use it in every echo we do. It's part of our workup. But at least for me, when I'm using it clinically, it's certainly not going to be the final say in whether or not I think a cat has an early disease or is at greater risk for potentially the disease. That's kind of where I fall right now. I by no means am I the expert, please, in diastolic function and TDI. I mean, I read everybody else's papers as well. So I'd love to hear kind of how everybody incorporates it, because I think it's so important to see how does everyone use it and how much importance do they place on it. So for me, okay, I'll give it a scale. I'll say if 10 is the most important thing I use and 1 is, okay, I did it, but I don't care. It's in the 6 to 7 range for me, but it's not quite getting up there with some of the other things that I think are important.
I think when I first heard about TDI and when people start using TDI to assess cardiomyopathies, maybe, 15, 20 years ago, I think there was this huge enthusiasm that TDI would help us detecting pre-phenotypic HCM and to be, as you were saying, an early marker of myocardial disease. And it feels like that enthusiasm slowly went away because especially looking at, there's certainly not much data in cats. I guess there's 1 or 2 papers from the group in Paris looking at genotype positive, phenotype negative Maine Coons that suggest something. But looking at even in human medicine at markers of pre-phenotypic HCM, it feels like TDI is not really that special weapon, holy grail that people felt like this could help us predict HCM and or other cardiomyopathies. And my impression is what we do is indeed, as you were saying, is mainly to use it as diastolic to assess diastolic function. Do you ever look at TDI to assess filling pressures, or is more a tool to assess diastolic function in your echo lab?
Yeah, I used to, I should say. I'm trying to remember about how long ago it was. Everything feels like it was 5 years ago, but you got to add another 5 or 10 years to it these days. So let's say 10 years ago.
Say that.
we were definitely looking at it with indices. So combining things, for a while we were using our early mitral filling to our E prime and then E to IVRT, and then now we're combining. And so for a while we really were trying to assess filling pressures. And what we found is that, or at least what I found, I should say, clinically, is that it wasn't as predictive as I would hope, and I think that goes into sort of the physiology of what's occurring in our patients, with their heart rate, their phase of respiration, the angle of these Doppler acquired indices can really, alter some of these values, and put you into these borderline or elevated ranges, and it doesn't always make sense. So I feel like when you have a cat who phenotypically has a cardiomyopathy, let's say HCM, and you feel like, yes, they have a big left atrium, and then you get an indice that suggests an elevated filling pressure, you feel good, and you say, yeah, this all makes sense. I'm happy here. But the more challenging scenario is when you have a cat who's phenotypically maybe nebulous or equivocal. Their left atrium is in whatever you consider be the borderline range, and then you get these really high estimations of filling pressures, or sometimes in normal cats you get these high estimations. So I feel like it isn't as consistent as I would like it to be for doing that. Of course, we do it, and we try to integrate that into our assessment, but it hasn't yet panned out to be like, okay, every time I get this indice, I know that this cat is definitely going to be in heart failure clinically, or in the near future. So that's kind of how we're using it. I think we use it in dogs a fair bit, when trying to assess for filling pressures, or at least risk assessment with mitral valve disease, but not quite as helpful, in my opinion, with cats for making that estimation.
Feels like it becomes much less reliable as soon as you start getting MR and changes to loading conditions, and it just feels like it leaves that nice correlation that has been reported, doesn't it?
Yeah, I agree.
I think once you add to that things like heart rate in cats, and arrhythmias, of course, again, it's another confounding factor. Do you have any tips for people who do use TDI in assessing diastolic function?
Well, I think for me, we are a lateral wall kind of crew over here. There's probably some science behind why that's a better choice. Um, my understanding, the lateral wall being, more movable, it has more options to sort of move, whereas the septum, of course, is less mobile during diastole. It's sharing part of its loading conditions and forces with the right ventricle. It can often be the hypertrophied section. And so there's a number of reasons we choose the lateral wall, but that does, in at least from a practical standpoint, allow for some error to occur, because it can be more challenging to try to line up the lateral free wall sort of directly down the center of your pulse wave gate. So one tip is always to try to decrease the angle between your transducer and the target, so the lateral mitral annulus. So it's not necessarily the prettiest four-chamber view. If you're using a left apical view or an inflow-outflow view, you sort of are swinging it to try to create that alignment there. Practically, I see I train a lot of residents, so I train a lot of people with very different experiences in echocardiography, and I think that our sort of our first year residents, or people who are first starting, they often struggle with kind of just where to put the sample gate, and how big to make the sample gate. And so, I always try to impress upon them that if we're trying to assess myocardium, might as well put it in the myocardium. I see them putting it on the annulus or near the valve, sometimes on the atrial side. So you really want to make sure you're in the ventricle, and you're along the muscular portion of that. There's papillaries and chordae and epicardium. There's lots of things. So you don't want your your gate to be so wide that you're incorporating some of the structures that you're not interested in evaluating at that point. Again, these tips are not ones that I made up. These are ones that were taught to me because I struggled and made all these mistakes as well. So, and then, sweep speed, gain, all of those are going to be important as well. And we try to use a high sweep speed and keep the gain appropriate, so that, it's not too bright, not too dark. Just sort of practical tips like that.
Yeah, that's very, very useful. Thanks, Ryan, for that. Also, from a practical perspective for our listeners, how do you deal with summated fused E&A prime waves? So if they are fused, do you still use them? Then you just ignore them? What's your approach there?
I've never figured out exactly what I want to do with a fused EA, E prime, A prime. So ultimately, I don't do things with them. I'm not measuring, I'm not using what's been reported as sort of the values that you could potentially use in these situations. So when I have a very high heart rate in a cat or even bradycardia or an arrhythmia, I kind of can't really integrate that into my clinical decision making. I've never been able to figure out a good way to do it. I don't know if you have any great wisdom in this topic, but for me, I kind of have to say, it's like one part that we're not going to get. It's like if your chemistry analyzer's down for the day, like you're not getting that part today. Just move on, and we're doctors, right? We can figure this out.
And it's rarely about one measurement, is it?
Yeah.
It's the constellation of things that we can look at on echo. And thinking about other echo measurements, other echo techniques, is strain something that you reach for with these feline cases?
That's a great question. And it is something that we are using more frequently now. One of the great things about strain is that you're already obtaining it. If you're getting the image, if you're doing two-dimensional echocardiography, which hopefully you are, then you're getting it. So it's really about optimizing the images and then having the ability to do the assessment on your software, whether that is directly on the machine or a third party somewhere later at another time. But it is something that we have been exploring quite a bit, and we are utilizing more. So I can dig into that a little bit, some of the research that we've done and some of the things that I've presented on. And so we've been looking at specifically longitudinal strain. That's been sort of a focus of ours over the last maybe 8 years or so. We still can look at things like circumferential and radial strain, but we've really kind of been digging more into the longitudinal strain aspect of things. And so for listeners that don't think about strain every day, what we're really talking about is our echo machine's ability to track the speckles that occur as an artifact of two-dimensional imaging, right? The heart it doesn't look uniformly black or gray. It's got little white speckles in it. And so the machine can track those speckles as they move, as they separate from each other or as they get closer together. And strain helps us overcome that limitation with tissue Doppler imaging when it comes to angle. So we can track how those speckles are moving relative to each other, regardless of their spatial orientation. So it's really, you can get really, really geeky into strain if you want. It is some really cool stuff, and I have really been impressed by how well some physicists can describe it in such a practical way. So I think it's pretty cool. One of the coolest things I'd heard someone describe was sort of this theory of distensibility. And the way they described it was, you've got a cube, imagine a cube in space, and you're gonna compress the cube from top to bottom with your hands. Well, you can compress it, but the sides are going to move out in some direction, right? They're going to move away from each other. And if you try to squish it back, then the top and the bottom move back. Everything kind of can be compressed to an extent, but there's a limit. So if you're going to stretch it in one direction, it's going to get compressed in the other, vice versa. And there's only so much that you can do with it. And that in at least in the physiologic world, so in the biology of things, it ends up being, if you're talking about compression, it ends up being, somewhere in that minus 20%. And that's pretty conserved across everything that we see biologically. And that just happens to be around the normal value that we see when we talk about strain, is that negative 20% compression, and that it's limited, right? And the reason you can't do that is because if you compressed it more, something would get destroyed on the other end. So knowing that, we can kind of incorporate how much is the myocardium able to really compress or squeeze down during systole, and longitudinal strain is really looking at systolic function rather than sort of the diastolic components that we think about when we're talking about HCM and some of the other strain values. So yeah, we're using it for sure.
Just if you could just also share with us now from the beginning, in terms of your protocol, certainly ideally we would use 3 different apical planes, which of course is at times complicated and difficult to achieve, and will extend the echocardiographic exam. Is it reasonable to use a simplified protocol where one would use just one plane, like a 4-chamber apical view? Or
we simplify it in our cats. The trying to get 3 views from the left apical perspective, I think 2 is understandable. We are often, I think an apical 4 and then sort of that inflow outflow view are pretty attainable and routinely acquired in cats. An apical 2-chamber is a very challenging view to get in cats, and it's going to add some additional time. And even when we are able to acquire that, I still feel like portions of the left ventricle are artifactually disguised, right? There's a rib in the way, or there's lung now. And so we're really not practically able to get it unless the cat is heavily sedated, and that's going to affect some of those values anyway. So we have not been utilizing a true 3-view, create a full bullseye to talk about strain when it comes to cats. I do utilize all 3 planes and create a bullseye when I'm using it in dogs. I think it's just easier to acquire. And of course, with some of the multiplanar probes now, you can acquire all 3 images at the same time. And some people think that's cheating. I love technology that's so efficient. My residents, I'm always like, no, go get them yourself. But I'm allowed to use the multiplanar to get it done all at once. But that technology doesn't exist on the transducer sizes that we need for cats. So we are typically assessing longitudinal strain simply from a single apical 4-chamber view. And we have applied that clinically and have found there to be some meaningful clinical outcomes associated with just that one value. So does that one value represent the global strain of the heart? No, it does not, but it does represent the longitudinal strain of the apical view, and that does have clinical impact in the cat populations that we've been assessing over the last 5 to 8 years. So I think it's not going to be textbook, but it is practical and it's useful. So we're utilizing that view.
And just expand on that utility for people who aren't familiar with the publications on it.
I've presented on it. I have some abstracts on it, and I'm working on getting it published at this point in time. But I'm happy to share some of that insight because I've shared it already. And, if you look sort of into the human literature of hypertrophic cardiomyopathy, and certainly cats are not people, and people have lots of different variants on HCM and phenotypes and their outcomes. But there's enough overlap that anytime something is being utilized, especially clinically, with our human counterparts, it bears some thought to say, well, does that apply to a cat? And so we started, applying that. This was over, I want to say it was 8 years ago. We started acquiring the apical 4-chamber view and then performing strain assessment on that view in cats who we had diagnosed with preclinical hypertrophic cardiomyopathy. Most of these cats at that point in time had to have what we consider to be at least mild left atrial enlargement as well. And the reason we chose that specific group was we felt that group we feel has at least a likelihood of achieving an outcome that is clinically relevant in the next 5 years or so, and that those outcomes being things like congestive heart failure or thromboembolism. Or many of these cats can kind of live in that land for forever and never have an outcome. And so left atrial size is such an important risk factor that we decided to see, would longitudinal strain provide any additional meaningful prognostic information? So does that strain value, whether it's in the normal range, low, high, whatever it is, can it give you any predictive power in which cats are going to reach the outcome of heart failure? And so we did that, and we found that yes, longitudinal strain obtained from a single apical four-chamber view in cats is associated with a negative outcome of heart failure, and it was correlated with the degree of strain. So strain is a negative number because we're talking about how close those pixels get together. And so the less negative the number, right? So if negative 20 is our goal, as we move to negative 10, negative 5, those are really bad numbers. Very obvious at that point would be systolic dysfunction. What we found is that has a negative association with the outcome of going into heart failure. And it was independent, but also summative with left atrial size. So it was an independent prognostic indicator, but by itself, I don't know how to apply that in a cat who doesn't have HCM or doesn't have a big left atrium. But if you have both of those things, you can really start to get some powerful prediction. I have a statistician who helped me create some pretty cool sort of maps and predictive models. And so sort of like a choose your own adventure option where you can say, okay, this is what the left atrial size is, this is what the strain is, and along this continuum, when do we think a cat might actually reach this outcome, which would be heart failure? And so I'm very interested in that knowledge, which is elusive to all of us, and that is to be able to tell an owner, hey, your cat has this disease, which I think we're getting pretty good at saying, but more important to the owner is what's going to happen to my cat now over the next 5-10 years. And I'm hoping that strain will, with integrating that into some of the already known risk factors, can help us refine that a little bit more. The model didn't have 1,000 cats. It had 100 and something cats, which is still a good number of cats. So the model could predict things, within 18 months, things like that, which is still very helpful because we've all been in that situation where we diagnose a cat with HCM. We have all the knowledge, right? We're telling the owners everything we know, and then we see the cat back in 6 months and it's the same cat, nothing changed. And then 6 more months, it's the same cat, nothing changed. And it would be nice if we had a little bit more predictive power. And I think strain might give us some of that. And that's what we're working on right now.
I think that's particularly true now that we're perhaps entering an era of treating the disease rather than the sequelae of the disease. So if there's a way we can add nuance to that decision, when do we start our treatment with, I don't know, down the line, myosin inhibitors? What does that look like? I think all of this data is super important, isn't it? Because otherwise, all we've got is big left atrial size, really, or atrial dysfunction.
Yep.
Yeah, indeed. No, that's indeed very, very exciting. Something that we brought a few times here at the podcast and is an interesting finding with hypertrophic cardiomyopathy. I think sometimes it becomes a bit confusing is when one looks at global systolic function, the disease is characterized by the hyperdynamic, hyperkinetic left ventricle. And so measurements like LV fractional shorting, LV injection fraction are very, very high. And once you start looking at strain and regional systolic dysfunction, then strain is abnormal. And so there is a subclinical systolic dysfunction. What do you make of that? And would that ever change how you treat a cat? Let's say that now we are in stage C, and Pimobendan is a controversial issue, and I was not going towards Pimobendan, but uh, maybe without even thinking about Pimobendan, do you ever treat a cat differently? Let's say if strain was quite low, even though let's say LV fractional shortening was normal. Does that have an impact on how you treat a cat?
Not yet. It hasn't changed what we're doing yet in terms of a preclinical treatment. If a cat is in heart failure, so that they're in stage C, they've developed effusion or edema, if their strain values are significantly lower, and they don't have an obstruction, I think I would consider using pimobendan in those cats. If the owners are on board and the cat's going to tolerate it, they're amenable to getting, a pill or liquid now. I think it's we're trying what we can do to really help these animals. So it hasn't changed my preclinical treatment, but it is, I think I'll reach for pimobendan in a heart failure cat, especially if I'm seeing a trend in that strain value. If it is going down, then I think there's, maybe that is an indication to starting that medication. I wouldn't say it's 50% of the cats that we treat. It's probably even less than that. And then once they have obvious global changes, then we're going to add in that medication. But I don't have a good algorithm for how I'm going to utilize it to guide my therapies yet. I think for me, it really changes how I risk assess that cat, when I'm going to see them back. Um, until we find that therapeutic option that is going to be helpful, I don't know what to reach for yet. And counterintuitively, a myosin inhibitor in the face of a decreased strain seems like a bad idea, but I don't know. Yeah, lots of things seem like good ideas that don't work in cats. So maybe, maybe the opposite would be helpful to some extent. And it's also not a disease of systolic dysfunction. So combined with that, we have to still integrate our diastolic parameters, our left atrial function. A lot of things go into it. It's not just one problem, one thing. And so there's more to assess. And
Yeah.
go ahead.
Yeah, that's why exactly where I was trying to go, because I think it's really so. That's also an area that we are very interested in on trying to predict adverse cardiovascular events in subclinical HCM. So it's pretty cool that your group has managed to show that strain can help us with that because that's indeed very, very interesting and of huge importance. But then in my mind, I always see strain as a marker of more advanced disease and help us detecting that cat has a more advanced myocardial disease than we can assess on 2D echo. But then in terms of, is that subclinical systolic dysfunction relevant? I'm not sure, because I think still the left ventricle as a pump behaves as a hyperdynamic pump. Even if even if in some regions there will be systolic dysfunction, overall the pump is still working as a hyperdynamic pump. And I think the example of that is, of course, that's why cardiac myosin inhibitors work. Until we reach a state, as you were saying, that there is clear global systolic dysfunction, I think overall the pump is still working as a hyperdynamic pump. And I'm very happy that you guys are working on that. And we will be talking soon about cardiac MRI. It will be interesting to see how your findings on cardiac MRI compare with strain. Maybe if we move now to contrast enhanced echocardiography, which is something that your group has been working on, and we have also been doing some work on it, which is an interesting field and readily available to many cardiologists and vets. Can you just tell our listeners what is contrast enhanced echocardiography and why would C-echo be helpful in feline HCM and echocardiographic assessment of cats?
Absolutely. So contrast enhanced echocardiography is the utilization of an enhancing agent. There's commercially available agents that you can reconstitute. So they're often you purchase them as a powder and then you reconstitute it with saline. We routinely use the product Lumison, which is a sulfur hexalipid product. So the saline interacts with the powder to create this lipid bubble, this hydrophobic little bubble, and they're very, very small. They're in the 3 to 10 micrometer range or smaller, and so these agents, given intravenously, are going to enter into the heart just as any other bolus would. But because of their really small size, but a high degree of stability, they can pass through the pulmonary circulation, through the capillaries, and then opacify the left heart, creating this really nice sort of opacification of the lumen of the heart. So all 4 chambers can be opacified. And in hypertrophic cardiomyopathy, or really any disease in which you want to have a really good assessment of wall thickness, contrast enhancing agents can be very useful in sort of eliminating a lot of the confounding artifacts, or not even artifacts, anatomy, that make it very difficult for us to measure wall thickness. As we all know, if you're echoing a cat, we're trying to differentiate 1 millimeter of wall thickness between a normal and an affected cat. And I think we do a really good job of that, even without contrast enhancing agents. But many of us struggle with anatomical features, such as an increase in endocardial thickness. How do you incorporate that into your measurement? Do you ignore it? Do you put it in there? It can start to affect things. If there are LV bands or insertions along the septum, and I feel like many cats have those, it really changes sort of the shape of the wall. And then there's the whole aspect of the septum sharing the right ventricle, and there are trabeculations, papillary muscles, insertions from the tricuspid valve. And all of these go into that measurement that we decide, is this hypertrophied, equivocal, or is this normal? And the contrast enhancing agents can really help you hone in specifically on the compact myocardium. And when done correctly, it creates this really distinct area that you can measure. And it really builds the confidence that, yes, there is a discrete or generalized area of hypertrophy. And so we're utilizing that in our practice. I know Jose's been using it some as well. And I think there's a lot of promise in helping us to measure the walls in cats more accurately and more repeatably. And those are 2 aspects of echo in a cat that we all know is challenging.
I think just for listeners outside of the US, I think Lumison is Sonoview. Is that right?
Mm-hmm.
Jose,
Yes,
is
that
that the
is
same
correct.
thing you've been using? So in terms of the practicalities of that, are you using in every case where you're suspecting a hypertrophic phenotype, or well, in any case, actually, because how do you know until you measure them? Or is this something you use for particular cases? And are you using it in cases that are presenting with clinical signs, or are you using it in a screening population?
Those are all really great questions, and certainly ones that we all probably collectively should figure out what is going to be the most practical way of utilizing this. We started with a clinical question, which is, does it help us measure the wall thickness, and does it help improve things like repeatability? And so at that point, we spent the better part of 6 months or a year using it in virtually every cat that we came in, and they got consent from the owners, and we were utilizing it. Using the results of that information, where we found that, yeah, this really does help us measure the wall thickness. It helps us repeat that measurement. It helps us between observers measure this. We now have started to select for cats that we think are in this gray zone where we don't really know what they have. So if phenotypically we're calling it normal and we have no questions about that, I think it's hard to underestimate wall thickness. It's possible, but it's not as common. That cat probably isn't, getting teed up for a catheter and some contrast. same story on the extreme end. If the cat comes in and its wall thickness is 8 millimeters and its left atrium is 20, we know that that cat phenotypically has a disease that this isn't going to help us differentiate from. So how wide is this area of cats that we should utilize it in? We don't quite know that answer, but we're using it right now. We used it yesterday in a cat who came in for a consultation, who we were measuring a wall thickness on two-dimensional images, both in the short and the long axis, of around 5.8 up to 6.3 millimeters. So this really sort of, do you have this? Do you not?
Right on the borderline of kind of
Right on the
decision
borderline.
making. Yeah.
And so we used contrast in that cat. It was a cat who already had a catheter in, so it was very convenient. I had some available, and so we utilized it. And as we have seen, is that the contrast wall measurements are nearly uniformly lower than the non-contrast measurements. And so we kind of wanted to know just how far is this going to go down. And it was a cat whose walls then, with just the compact myocardium in all the segments, we didn't get a single measurement that was above 5.2. And so we felt pretty confident in this. I don't know, it was an older cat. You're not, I don't need to see you again. I'm not worried. Let's get you back to the service that you came in through. Let's manage those comorbidities. Let's not add one more problem to your plate for you to come in and see us every 6 months for the next, several years. And we felt that we could confidently say, yeah, this is not an affected cat. So right now we're picking and choosing, but I think that equivocal range tends to be the most frequently utilized in our group. We haven't decided the top end, though, of what that is. If a cat measures 6.5, should it get contrast? I mean, I think we're pushing it and trying to figure that out. And collectively, we can all kind of work together to build that database.
It's crazy, isn't it? It's
No, I mean, I'm sitting here thinking, oh boy, all that research.
Yeah.
How valid is all of that before all of the cases we say, yeah, this cat had a median survival time of whatever and a wall thickness of 6.15. It feels crazy that maybe all of that data, I'm not just talking about data I published, but I am not talking about data I published, looking at cats, and I just wonder about the validity of it in light of this. And I watched Jose present an abstract at, was it ECVIM? I think it was, on using contrast medium in cats, and the findings there really echo, no pun intended, what you're talking about. And I just sat there thinking, oh boy, this is really going to change things. I would love to be using this more in our clinic, and questions that I have, because I've never used it. I mean, we've all done bubble studies, right? But the question from a bubble study is different. The utility of a bubble study is different. But actually, one question that comes from that idea is, if we're thinking about right ventricular structures, the right ventricle smaller, is more trabecular, there's tricuspid valve apparatus. Could we just use a traditional agitated saline bubble to look at those structures and then presume the left-sided structures are clearer? And are there any other technical issues? I mean, we've got to place an IV catheter, sure, but do we need to adjust our machine in some way? Do we need a different probe selection? Do we need to think about those aspects of it as well?
Absolutely. Great question about, could we just use a saline agitated to try to help us opacify the RV better, to give us better delineation of at least that septal portion. I don't know. That great idea. Let's write that down and come back to that, because that could be a very useful, practical, everyday type of way of getting to that part.
It would certainly take away some of the cost implications and storage implications of
and the technical aspects that you are asking about, because contrast enhanced ultrasound does require some nuance and differences in how you acquire the imaging. So the bubbles themselves are stable. However, they're very delicate. And so they will be destroyed, for lack of a better word, by the ultrasound and the energy produced by the transducer itself. And so there are settings on machines that can allow for you to image without destroying the bubbles themselves that you create. And so the most important feature or aspect on the machine is what's referred to as the mechanical index. So that's basically the power, if you will, of the transducer and what's coming out of it. And so the higher the mechanical index, the more it's going to be able to destroy the bubbles themselves. And so the mechanical index needs to be very low in order to keep these bubbles around for a long time. I think Lumason or Sonaview says that they are destroyed somewhere around 0.8 on a mechanical index. But if you want to opacify the left ventricle and see them really well, the mechanical index should be even lower, somewhere around 0.3. This raises a really good question. So when we're using contrast enhanced ultrasound and we're using it, say, for example, to assess something like myocardial perfusion or in a dog, we will always utilize that setting with a very low mechanical index in order to see that. With cats, I've played around with using the very low mechanical index settings as well as some of your traditional settings. And I'm kind of stuck. I think I see the 2D image so well with traditional imaging, and the bubbles come in, they opacify, they allow me to make my measurement. And yes, the bubbles are being destroyed very rapidly, but it's allowing me to do what I'm trying to assess clinically. I don't really need the bubbles to be there for 4 minutes. That's not what I'm looking for. I only need them to come in, do their job, and then they can be gone in a minute. That's fine. Where I feel the biggest or the most important aspect with an echo with a cat and these bubbles is going to be the frequency of the transducer that you're using. So most of us have a very high frequency small transducer that we like in cats, whether that's your 10 or your 12 or whatever one you use. And at least with the machine that we were using for our study, which was we were using a GE machine, if we had it set on that 12 megahertz transducer, we weren't getting great contrast imaging. The bubbles were being destroyed very rapidly. So we either had to, use the lowest frequency setting on that transducer, or in fact choose a slightly larger transducer, something like the 8. And the sweet spot for us was around that 8. We were getting still very good imaging, and I think the technology on an 8 transducer now is good enough to get spatial and axial resolution to actually measure these things and keep those bubbles around long enough to get really nice measurements. We just recently started using a Siemens machine, the Origin. It's a really nice machine, and they have a 10 transducer, and we haven't needed to make really any adjustments when it comes to imaging the cats. We're able to get really nice opacification without a lot of bubble destruction. So I don't know what that perfect setting is for everyone on all their transducers on every machine. I think you have to play around with that a little bit, but you're going to have to go with a slightly lower frequency than what you're used to when measuring sort of just your 2D image in order to keep those bubbles around. Jose, you've been using it a little bit. Do you agree with that?
Totally. It has been exactly our experience. So we have an Epic 7, we use Philips, and very similar to what you said. We start with the 12 megahertz probe, and the bubbles didn't last as long as when we use our 8 megahertz probe. So a bit of lower frequency is better, which is interesting because looking at the mechanical index, the mechanical index is similar. I think in our study range from 0.6 to 0.8, so in the high range, if we consider the human range, as you mentioned, but the frequency does play a role. And as you were talking about strain, I think it's fascinating when you start reading about the physics of microbubbles, because it's all field, isn't it? How bubbles behave, how much they vibrate and oscillate, depending on the frequency and the mechanical index. It's really interesting, all the science behind. But no, totally with Philips, that has been also our experience. And you said it all, Ryan. So thanks for sharing your thought on that. And it's so fascinating, really, that we And when, especially again, when we look at someone like your team, that the cat you have just mentioned, and I'm sure you measure it very, very carefully, and you are aware of what is the compact myocardium, and you need to avoid trabeculation, blah, blah, blah. And still you go from 5.8 millimeters down to 5.2 or 5.3. It's so fascinating how difficult it is for us on standard echo to really assess the compact myocardium and to know exactly this is a compact myocardium and not false tendon or a trabecle and so on. Yeah, it's fascinating. If you don't mind also sharing with us how like practical stuff regarding the vial, how long do you use one vial? Uh, we kept so for the listeners that are not used to contrast mediums, classically you reconstitute the solution to 5 milliliters. I think in average a cat will receive like 0.2 0.5 milliliters. So we kept it for 24 hours on a fridge. How do you manage your cats? For how long do you keep the vials? And yeah, that would be great to know what you've been doing.
Yeah. So I have a cardiology specialty intern, a research intern, and this has been her project. And so she's nearing completion of it, which is great. And so we recognize one of the limitations of contrast enhanced echocardiography is the agent. So there's an expense associated with this. In North America, it ends up being around $180-ish, I think, for a vial. So if you're going to use 0.2 mils of this 5 mils solution and then you throw it away, no, that adds quite a bit of cost to the echo. So if we can spread it out, use it in multiple patients, that would be ideal. And so the package insert, at least here, says, only one time use it within 3 hours, and then it go away. So we set out to answer the question, well, do the bubbles remain in this suspension, and do they create the artifact that you want to see and you can utilize it longer? And so we first set out to say, okay, well, what if we just inject this into some saline bags and we echo these bags every day for 5 days? Are they still there? And if we quantify the degree of pixelation, does it change? And so she first did that, and what we found was that the artifact and the pixelation intensity was maintained over the course of 5 days, at least in saline. And so we thought, oh, this is great. So clinically, maybe we can use it more than just once, and if we store it under the right conditions, we can utilize this. So we don't have the information back yet, but then we set out to reconstitute it, store it in 2 different conditions, either under refrigeration or at room temperature, and we cultured it every day to see, does it grow anything that would be potentially harmful to our patients. So we're waiting to sort of get back the culture results to find out if anything grew. And then the last final step, assuming that we're culture negative or however long we're culture negative, is to then apply it clinically and say, it looks fine in a bag and it didn't grow anything, but does it still do what we want it to do in terms of the opacification over time? And so could you reconstitute a bottle of this on Monday, store it under the correct conditions, and utilize it all the way up to Friday, or at least until it's gone, and be able to spread out that cost and use it clinically? And so we don't quite have that answer yet, but we want to answer this question because practically it's just not really something that you can use for one dose.
Have you ever seen any adverse reaction? Because they are very rare in humans. Looking at the canine and feline literature, when imagers use Sonoview and other mediums is extremely rare. If we have never seen any adverse reaction, have you ever come across with any adverse reaction? No.
We have not. No, we're aware of it, and so we kind of look for it regularly, but we've never seen an adverse reaction.
Nice. Yeah. It's such an exciting field, isn't it? Because especially if you can use it as hopefully your study will show for a whole week, would be such a nice add-on. Okay, you need to place an IV catheter. I think that's the major bottleneck. Because other than that, it's such a nice modality.
I think though, from a conversation, a spin, if you will, for the owners is to say, I would like to place an IV catheter and do this additional assessment and what what is the outcome, it could be one of two things, right? I am now confident that I don't need to see your cat back. I just saved you another echo, another visit, another put your cat in a carrier.
That's the win.
I just saved you that for the sort of momentarily issue of putting a catheter in your cat. Or what I've done is I've said, now I have a high degree of confidence that your cat is not normal, whether we can say it's affected yet, but I absolutely need to see your cat back. And I'm certain that you need to go ahead and put that cat back in a carrier and then travel across town and get here to do this. So, yeah, I agree. We have to put an IV catheter in, and that's why it probably wouldn't be practical to do it with every cat every day all the time. But if you're selecting for those cases where right now I kind of use it, my guiding principle is if I'm not sure, why not see if I can be more confident?
It's not a big deal, really, because it's a change to our usual protocol. Put in an IV, give an agent. We, by default, are thinking, oh, this is going to be a hassle. But we'll take troponin if we feel it's indicated. So it's the same thing. And actually, with the troponin, you spend, I don't know, £100 in the UK, maybe, and you ship it off to the lab and you have a lab tech spin it down. And that's actually a much bigger hassle. But because it's something we already do, it doesn't feel like an issue. Whereas here, it's a change in our protocol, it's a change in how we're thinking. But it's easy, really. And probably even the cost is something we could overcome.
Mm-hmm.
Great. And I think to talk to clients are so familiar with the need to use contrast for MRI and CTs. So it makes a lot of sense that we may also need to use contrast on echo.
Yeah, maybe they've had it themselves.
Yeah. Very, very exciting. Very, very exciting. Very exciting.
Thinking about something
Contrast.
exciting, but which is much more intense and invasive and expensive. I'd like to move us on to cardiac MRI in cats. We talked about the echo and the sort of more advanced echo techniques and contrast. Let's think about MRI in feline cardiomyopathy, because this is a commonplace diagnostic test in humans where there's any query about cardiomyopathy, family history, any smell that might hint at a vagueness of cardiomyopathy. MRI is a really important diagnostic step. Where are we with cats?
As will be abundantly obvious, I'm very biased about where we are with cardiac MRI. But I'm very fortunate to have had training in how to perform cardiac MRI and assess it. And so I have the advantage of being able to do it myself, and I have the equipment here. And if a cat is here, I can offer it and it can be done. That is universally untrue for, I think, everyone else. Even if you have access to it, you might not have the people who can do it or the experience with it. So I have to sort of couch my enthusiasm with what is the reality of cardiac MRI in cats. And so I think there's part of me that understands it is a future direction that we can utilize and should. And then there's a part of me that says it's also not practical, unless we have true hypertrophic cardiomyopathy referral centers where everyone's bringing their cat for that. And then everybody sort of integrates their imaging together and comes up with this great plan, maybe in our lifetimes, but probably not. So where I fall with cardiac MRI is I'm not recommending it for every cat that we diagnose with HCM. I don't think that there's enough clinical application to it, right? In people, they've got so much data from the information they garner from an MRI that they can truly make a stratification and almost alter the diagnosis to some extent and put these people into very different boxes, if you will, of what disease they have. Yes, phenotypically, it all looks the same. And that's where we are as well, right? We do an echo and we say it's left ventricular hypertrophy. The wall is X millimeters thick. The left atrium is X millimeters large. And you have HCM and off you go. And we then follow this cat. And we make all of our clinical decisions and outcome assessment based on what the echo told us. But where cardiac MRI has really shifted my perspective with the work that I've done is that when I do a cardiac MRI on those cats, I find that they're very different in terms of what their hearts look like with a cardiac MRI. Not from a structural perspective, because the wall thickness is still the wall thickness, LV mass is LV mass. But when we get down to the tissue characteristics, so what comprises that left ventricular hypertrophy, those cats can be very different. Some cats, their hypertrophy is driven by true myocyte hypertrophy. And the rest of the components of the myocardium, so the interstitium and the blood, the capillaries, everything else remains pretty stable. It doesn't change dramatically. Whereas other cats, their hypertrophy is not driven entirely by, or maybe not at some point, just by the myocyte hypertrophy. Now they get this really, profound expansion of the intracellular space, the extracellular matrix, the amount of collagen and fibrosis that's present becomes the driving force to their hypertrophy. And those cats have different outcomes. They just do. And so you brought up earlier about, gosh, are we going to have to redo studies if we don't know how thick a wall is? I'm wondering, even if we know how thick the wall is it the same stuff? And if it's not, can we truly put those cats in the same box, especially if there's a way for us to determine that there's a difference, right? And so if cats are like people, there's a difference. And those differences are really important. And their prognosis and their major adverse events are different. Their arrhythmias, their sudden death, they just have different outcomes. And so I wonder if we would be able to build that degree of data to look at cats as well.
Makes you wonder if you could establish how different those cats were on echo. So we find the two different groups you're talking about on MRI.
Yeah.
And then we reverse engineer it and look at the echo. What's different on the echo? What are we seeing? How do they cluster if we look at them as those groups? I think that's super interesting, particularly with the idea of bringing machine learning into the analysis of big data sets like that. When I think about MRI in human cardiomyopathy, I think about scar and sudden death risk, well, arrhythmia risk, and therefore sudden death risk. Where are we with scar tissue, and how do we assess that in cats? And is there any utility in assessing it as things stand?
So scar, and in people, right, they'll talk about an enhancement pattern, right? So an agent is delivered, gadolinium-based agent. So it's paramagnetic. It gets taken up into the myocardium. And then in a normal tissue, the capillaries will eventually sort of equilibrate with the blood, and everything sort of is homogeneous. But that gadolinium, those little particles of it, will be trapped in areas that are not perfused well, such as a scar, or even the extracellular matrix itself. So in the MRI world, we can run a scan sequence that helps us establish what is the baseline myocardium, what is the null of the myocardium. And then if we know that value, that inversion time, we can then run a second scan that would look at things that are different than that. And that's where the gadolinium would accumulate, and it becomes this area of bright intensity on a cardiac MRI. And in people, having a scar anywhere in the left ventricle with hypertrophic cardiomyopathy is profoundly associated with adverse events. In particular, arrhythmias and the risk of sudden cardiac death. It's actually one of the major criteria for considering something like a defibrillator in a person. So it's really important. In cats, very few, if any, cats have these discrete scars, these areas of obvious large infarction. I just have not appreciated that really in maybe but one or two cats I've ever done a cardiac MRI in. Wow. And in some of those cats, there are these there are these breeds of cats that I feel like routinely end up with regional dysfunction. So one of them was a Sphinx cat. I feel like Sphinxes do this. I don't know. Maybe I'm just imagining it, but I feel like, these are hypertrophic cats, and then a year or whatever later, their wall is thin now. It's not moving. You're like, oh boy. And so I've seen that, but it was obvious from the echo that that's what I was going to find. More commonly, what we see in cats is that they have expansion of basically all of the interstitium. And so the reason you're not getting this contrast between normal myocardium and this bright scar is that it's sort of uniformly distributed among the interstitium. So gadolinium enhancement isn't going to work because there isn't normal next to abnormal. It's sort of just all sprinkled between. It's like you've put it in the blender and now you've hit the blender button. All the parts are all homogenized together. So instead, what we focus on is parametric mapping. So we can use the inherent relaxation properties of different tissues. So in MRI world, we talk about T1 weighted, T2 weighted, and sort of how protons relax. And so muscle has a different relaxation time than fibrous tissue or collagen. And so if we get a baseline map of the myocardium before contrast, and then about 15 minutes after contrast, you can put those two maps over the top of each other, subtract what you know to be blood, and what you're left with is what is the extracellular matrix. And so how much, sort of collagen or fibrosis is occurring. And so in cats, what we see is more of a diffuse fibrosis rather than sort of a scar that occurs. And diffuse fibrosis is important in people as well with HCM. It does impact outcomes, maybe not as profoundly as a scar, but it does impact outcomes. In one of our studies that we looked at, we found that, to sort of bring it back to the beginning, that the amount of fibrosis that was present was associated with diastolic dysfunction, and specifically, it was actually associated with left atrial dysfunction. And it kind of
Amazing.
makes sense to me. I'm like, well, that makes sense, right? Even
Right.
if the wall isn't as thick, but it is more fibrotic, if it's stiffer, it's going to have more inherent diastolic dysfunction, and it's going to be harder for blood to pass from the left atrium into the left ventricle. And we're going to see changes in the left atrium, perhaps more profoundly than in a cat who maintains, even with hypertrophy, but they maintain more muscle, if you will. So it's really very interesting. And I would love to just do MRIs in cats all day, but that doesn't pay the bills.
Yeah, no, that's really, really cool. Regarding the extracellular volume assessment, can we then distinguish an increased extracellular volume due to fibrosis, interstitial fibrosis, from edema? How would you distinguish an increased extracellular volume from fibrosis versus myocardial edema?
So the way that we do that, and we do, is the parametric mapping comes. You can apply different scan sequences to assess that. And so when we're looking at sort of the T1, what we're looking for is the fibrosis perspective, and so we're looking for that. But we also do a T2 map. And the T2 map can help us assess for the edema part itself. So we create multiple maps with and without contrast, T1 and T2. You can also do a T2 star map, which helps you look for iron overload, which is not something that we've ever practically seen. So I don't routinely do that one. But we do T2 all the time to look for edema. And there is not much, at least in the HCM cats that we've looked at, edema or anything actively going on. I think an area that I would love to be able to apply this to would be to apply it to cats who are phenotypically HCM, but then have a transient cardiomyopathy that then ultimately...
We were all thinking that.
But how do I know which cat is transient until afterward? And so again, I think our human counterparts have such an advantage, to your point, where phenotypically you look like hypertrophic and your follow-up is an MRI. And now they get all this information and they can say, great news or bad news. Here's what we found on the MRI to really help us hone down on the phenotype of what we think you have.
It's so difficult, isn't it? It's so difficult, isn't it? Because we see these cats, and I think we all probably have a little inkling of, oh, this cat maybe has a TMT phenotype. There's something about them. They're young, female. They've got really bad heart failure, but their echo changes are not that bad. And maybe they're hypotensive, hypothermic. The troponin's high. So we all think, oh, that'd be really interesting. But who wants to anesthetize that cat and put it in the MR? And the same goes for those unstable hyperthyroid cats. And I guess once you get them stabilized, then you've got to have that conversation with the owner. Do we do the MR now that your animal's well and that things are getting better? Maybe it will help us, maybe it won't. It's really challenging. So I love the idea of being able to obtain some baseline data and then look at the outcome for those cases. I mean, it's definitely better for the cat than taking biopsies or pathology. So I think that's the only way we're really going to understand those transient phenotypes of cardiomyopathy.
And another, as Ryan was saying, what I think is really exciting is all we see on echo is LV thickening. We cannot characterize the myocardium. We do not know why the walls are thick. And my hope is that there are also other phenocopies out there, storage diseases that are so well described in humans that we don't know, and we think they are hypertrophic cardiomyopathy. And
they've got to be there in cats, haven't they?
Yeah, exactly. And so will be the ability to characterize tissues it's so cool and exciting. So with that, Ryan, and again, we are talking about the center where we have been doing a lot and is a very well-oiled machine. But how long in average takes your team to do a cardiac MRI in a cat?
So cats are they're the, I would say, the most efficient or the fastest MRIs I do, and that's because their heart rates tend to be higher even when they're anesthetized, and so scanning, you have to gate it, but you're able to obtain the sequences pretty quickly because their heart rates are relatively high. When you put a big Doberman in there with a heart rate of 50 and their heart's really big, it takes a while to get 16 slices of the ventricle. But
and
in
they've
cats,
got trying to say arrhythmia and the machine doesn't like it. And
yeah. So I will tell you that the longest time that it takes to do the MRI is actually waiting the 15 minutes between the delivery of contrast and when I can do my post contrast. So to get all of my pre-scans done, I usually am able to get those done in about 12 to 15 minutes. Then I give my contrast. I do my volumetric assessment while I'm waiting because what else are we going to do? And then I get my post image. So I was just looking at this. Cats, the average MRI is about 35 minutes. And then in dogs, our average is about 45 minutes. So every one of them is less than an hour now. It was not that way when I started, guys. It was not even close. It took me.
I think that's really efficient, those timings.
Yeah, that's really good. Yeah.
Yeah, and I've even been looking at some comparison. So right now we do everything is gated, and everything, so we can make these beautiful images. But I've been looking at still gated, but free breathing, free scan type sequences, which are going to drop your resolution a little bit. But I'm comparing. Am I getting different information? So basically, am I still getting the same volumetric assessment, functional assessment, wall mass, all of those things with this slightly lower resolution image? But I'm able to do that LV scan, and in a dog it takes 15 seconds. But if I'm doing breath holds and it could take 3 minutes to get that same scan done. So could I get a anatomical non-contrast study done in a cat or a dog in under 10 minutes? And I'm getting pretty close. And so I think, time doesn't tend to be the limitation. It's really the anesthesia, because we are limited. I don't do MRIs in unstable patients. I would love to do it in these TMT suspected cats at the time that they're having the TMT. But we are not recommending it. I'm just not comfortable. I don't want to lose a patient for that purpose.
When you lose a patient out of your own curiosity, I think you haven't got the right boundaries there, have you? So I think we've really got to prioritize that.
Yeah. But then as we get better, and your group is a good example of that, then things will be faster, smoother. And there was a cardiologist that recently presented at the Veterinary Cardiovascular Society here in the UK that he's looking at AI algorithms to improve MRIs, cardiac MRIs in babies. And it's amazing what they can do with non-breast hold scans that the quality is poor, and then their algorithms can improve the quality to a point that is similar to a breast hold cardiac MRI. I think AI will play a huge role in machine learning on that, on improving. And it's like he showed images of babies that moved during the MRI, and then they were breathing very heavily, and the image was all over the place, and they were able to improve and fine tune the image to the point that you could not then distinguish from a nicely done breast hold. So with that, and then I was telling him about the challenges and so on, and he was like, I'm sure you'll be able to do cardiac MRIs in cats in a few years. That initially the image was not. He was saying that interestingly, in human patient already, people will not go to MRI to do the MRI. MRI will come to their bedside, and they will do the MRI there, and then the image will be improved with all the post processing that AI can do. So yeah, very exciting, very exciting field. Ryan, can I just ask you, because it's an important classic question regarding magnet strength. I'm sure you're using a 3T, but do you think it's feasible? Could people use a 1.5 Tesla? Would that still give you some information, or we would always need to aim for a 3 Tesla?
No, you definitely do not need a 3T to do cardiac MRI. 1.5 T was the foundation of all cardiac MRI for years and years and years. So if you go to a human cardiology center right now, they'll have both. They'll have a 1.5 and a 3. So the signal to noise ratio is better with a 3T. So your resolution theoretically is better. The challenge, though, is that with the more powerful magnet, you're going to have a greater potential for artifacts, because the beam itself, so the magnet, is not the exact same strength from the center, the isocenter, all the way to the ends of the bore, right? So they are going to change. There's some inhomogeneity of that field. And so if you're starting at 3 Tesla, then that magnitude of change is greater along that. So good news is with a cat heart, there's not a lot of difference in that field, but a dog, there can be some changes. But 1.5 Tesla is going to be excellent. So I think a minimum of 1.5. I don't think you can go below that. The scan times will take way too long. But both of those allow for things like parallel imaging. So really rapid, allow for beautiful cine real-time imaging of the heart. You can even do 3D of the heart from 1.5 or 3 Tesla. The only thing that is not interchangeable between the two of them is some of that mapping that we were talking about. So T1 times, T2 times, and then your ECV or extracellular volumes are going to be different at different field strengths. So you can't use a published reference range from a 3T and just say, oh, well, I got this value, so it's abnormal. No, you have to actually establish it for each field strength, and then you should validate your own center. But you can definitely use the reference values as guidelines as long as you're using the correct field strength of the magnet.
And are those assessments vendor independent, or then they will also be vendor dependent?
There are going to be variations within the vendors themselves, so slight variations, and that's because of the scan sequence that's used.
Yeah.
So there's a whole bunch of different modified locker scan sequences, and some use this window and some use this window. So they're slightly different if you're using a Siemens versus a GE, Canon, whatever. But if there's a center that's going to be utilizing this, it just, you want to establish kind of what your normal is. You can use the published reference ranges to sort of begin the process, but once you've amassed, your whatever 25 or 50-ish normals, then you can sort of establish your site specific one to look for these minor changes.
Amazing.
Well, it has been fantastic. I think we covered a lot of stuff. It's been really, really interesting, Ryan. Thanks.
I'm off to go and MRI a bunch of cats with acute severe heart failure signs to try and establish what the heck is going on in those TMT cases.
That would be amazing. Thank you for doing that. I really appreciate you.
Someone's got to make the sacrifice. I was just going to ask one question that I guess kind of sums up a little bit. We've talked about all of this stuff, which I feel like we're on the cusp, really, particularly with the contrast, particularly with the MR. I feel like we're on the cusp of beginning to use it a bit more routinely, particularly in the centers who have got the experience, the expertise for it. What's the next step? What does the future hold when these things become more routine? What's out there on the horizon? Or is this as far as we can see right now in cats?
One thing that I've been thinking about a lot recently, and I think I can see your face, people on the podcast can't, but you had this expression when we were talking about contrast enhanced echocardiography and how it can change ultimately a diagnosis.
That was my facial expression when the bottom is dropping out of my world.
Part of me thinks we can leverage that feeling. No, we can leverage this knowledge to push forward again with some of the questions that are left sort of longing in our field, where we have these really good ideas about a therapeutic that should be beneficial or shouldn't, or whatever the scenario is. And then statistically, it just doesn't pan out. And I think part of that can go all the way back to case selection. And I've been thinking more that it would be not attainable, but it bears us starting, that we should at least endeavor to start again, to say, okay, let's go with whatever therapeutic or outcome you're looking for, and say, let's not equivocate. Let's be absolute and say that the cats had to have a wall thickness of 6.5 millimeters or greater with contrast. And can we all agree? Probably not. But could we all agree that that cat has a hypertrophic phenotype? Maybe transiently, but at least, hey, we tried. And so what we're weeding out over time are these cats who maybe regressed or never had it in the first place. And so I just have often wondered how many cats in our studies, I'm guilty as well, didn't have hypertrophic cardiomyopathy.
Yeah.
Didn't even have a phenocopy, just truly had poor imaging quality. And they are the ones that are really diverting us away from progress. And so it really allows for the skeptical conversation in our heads to be the loudest, which is we can't do anything. Cats are just really hard and nothing works. And we're all resigned to being, monitors of their progression without interveners. And I hope that we can think about, multi-centered studies where we are selecting for phenotypes using the most advanced and sophisticated imaging that we know and have available to us. And so that would be things like contrast and potentially MRI to really give us the best, starting point. And that's kind of where I'm hoping we can move forward. And then from that, we will be building our clinical data. We'll be able to then start using that to apply how the masses, if you will, can start utilizing this every day. Because right now, there's just a few of us doing these things, and it's just not enough for us to be able to say it's making a difference. But I'm hopeful.
Totally agree. And during my PhD, I've thought a lot about that when we were genotyping cats, because that might have been potentially a reason why we have not been successful with finding mutations, because it's very difficult for us to know exactly what is a normal cat, right? And maybe some of those cats that we have considered they were affected, they were not affected, and they were just cats that were not measured properly. So yeah, 100% agree. I think by being very careful at defining the phenotype, that might have a huge impact. And it's crazy, as you were saying, and I think we underestimate that once a cardiologist told me that they struggle in humans to distinguish between 12 millimeters to 15 millimeters. It's really difficult. And they're talking about difference in 3 millimeters, 4 millimeters to call someone affected versus unaffected. We are talking about half a millimeter, right? In a cat that will not stop, and the heart rate is 220. So it's really, yeah, certainly, it's impossible. It's impossible to be able to, even with perfect images, even if the image is perfect. And the example is the one you said. I'm sure your images before, we have seen this with contrast. The image, you feel like this is a pretty good image, and I know where I'm measuring. Then when you have contrast, well, you have not seen that trabecula, and the compact myocardium is thinner. So yeah, that's a really good point. We should all start using contrast to define our study populations.
It's at least a start, right? I'm not saying we're using it to completely change everything. I don't know what the cutoffs are going to be, but if we're using something that maybe we can all agree is well within the affected, and we've eliminated a potential confounding factor like a trabeculation or an LV band, maybe that will give us slightly different outcomes and help us see sort of a path forward.
Fantastic. Dr. Fries, much appreciated. Honestly, we could chat for much longer, I think, about all the different ideas that this conversation has generated for us. But yeah, thank you so much. I'm sure our listeners are going to take a lot of inspiration from this episode.
Well, thank you for having me. It was a blast. I love talking about cats and MRI. So this is the best morning I've had in a while. I appreciate it.
Thank you very much. You have been listening to the Animal Heartbeat. If you would like to reach us, email us on animalheartbeat@gmail.com.
Remember to like, follow, or subscribe wherever you get your podcasts, and check out the website animalheartbeat.com.